Good morning. Welcome to Epilepsy Grand Rounds. People in the room, please turn off your cell phones and pagers. This morning, I'm delighted to introduce Dr. Melanie Boly, who will present a subject that is very crucial for neurologists and epileptologists in particular. Alteration of consciousness is one of the most burdensome manifestations of epileptic seizures, and recent research has shed some light on the subject that was unknown prior. Dr. Boly is one of the experts on the subject. She went to medical school at the University of Liège and did her clinical training at University of Wisconsin, where she's now an assistant professor of neurology. For the past 19 years or so, Dr. Boly has studied subjects of alteration of consciousness, including states of vegetative state and anesthesia and sleep, and of course, epilepsy. The goal of her research is to combine different diagnostic modalities, including PET, fMRI, and also TMS and high-density EEG in order to understand the neural correlates of consciousness in health and disease, with the goal of devising interventions that can lessen the impact of such disorders on patients. Melanie's CV is very impressive and enviable. She has published 148 peer-reviewed articles, and her Google Scholar H-index is 70. I don't think I have to say any more. Without further ado, Dr. Boly.
Thank you so much for having me. I'm very honored and very grateful to be invited here to talk about a subject that is very dear to my heart. Loss of consciousness in health and disease, as you said, and relevance for epilepsy. And so I have to flash some slides about epilepsy board review course that is coming up, and the fact that the lectures are archived online. I have no relevant commercial relationships to disclose. And the learning objective of this session would be to understand the major health burden created by loss of consciousness during epileptic seizures, and evaluate the recent scientific evidence dissociating consciousness from responsiveness and also their neural correlates in health and disease, and also understand the potential relevance of the progress made in the field of consciousness science to identify also the mechanisms of loss of consciousness during seizures. And so there is a CME accreditation that you can also review online, and I'll just let you review this. So basically the title of my talk is Dissociating Consciousness from Responsiveness and Potential Relevance for Identifying the Neural Correlates of Loss of Consciousness and including during epileptic seizures. The talk will have 4 parts. I'll start with some definitions and stating the clinical problem. And then I'll review the available evidence for the dissociation between consciousness and responsiveness and their different brain mechanisms, some relevance for epilepsy, and also ending with some measures of complexity that also seem to be a very promising marker of consciousness in health and disease. So when I talk about consciousness here, this is a definition I use. The one we used also was Giulio Tononi in Nature Reviews. Consciousness is subjective experience to what it is like, for example, to perceive a scene, to endure pain, to entertain a thought, or to reflect on the experience itself. All these different kind of experiences are for some forms of consciousness. And when consciousness fades, as it does during dreamless sleep, from the intrinsic perspective of the experiencing subject, the entire world vanishes. The neural correlates of consciousness have been proposed as a scientific approach to tackle this topic by Crick and Koch, and the stated we needed to search for the minimal neural mechanism jointly sufficient for any one conscious perception, the NCC. And for every conscious perception, there will be one NCC, and inducing the NCC will induce the perception, and inactivating it will eliminate it. There are 2 main approaches, very complementary to study the neural correlates of consciousness. One is a global approach where you actually contrast conscious versus unconscious states, for example, dreaming during sleep. So what it is like to be conscious versus not being there. And then the other one it's in conscious subjects, so it's a different question. The subjects are conscious already, but you're actually looking at what makes a specific conscious content to be there or not, the quality of different experiences. And for there are different approaches that have been designed over the years, including some stimuli at threshold, and you detect them or not, or I'll talk about some other approaches, like contents of consciousness during dreams, or seizures, for example. And so, epilepsy and consciousness, as you know, impairment or loss of consciousness is a cardinal feature of many epileptic seizures, and it can take different forms, in the forms of generalized tonic-clonic seizures, or staring episodes, complex partial seizure. And there's a very major health burden related to it. There are many negative consequences, like the decreased ability to work or drive, difficulty with learning and schooling, social stigma, and also a high risk of serious injury and sudden death that come especially with generalized tonic-clonic seizures. And they're still poorly understood. How come that some seizures generalize and some don't? And why is there that risk of sudden death afterwards? Documented SUDEP cases occur most often during the post-ictal phase of generalized tonic-clonic seizures, and we still don't know why. And persistence of loss of consciousness during seizures is also one of the main measures used to assess epilepsy surgery outcomes. There was a recent change in the classification of impaired consciousness during seizures by the ILAE, when they recently reasserted that impairment of consciousness indeed has a clear role for classifying focal seizures and for patient management, and they say that consciousness remains in the classification, but awareness is in the seizure name. And what they propose, which is very relevant to this talk, is actually recognizing that there are different measures we can use, different proxies for consciousness, including consciousness per se, or awareness of self and our environment, responsiveness to stimuli, or memory of the time during the event. But interestingly, actually, the definition of awareness that they use, like the knowledge of self or environment, is very related to something I grew up with when I did my PhD in coma, which is Plum and Posner's definition of consciousness for coma patients too. So there's actually some interesting parallels to do there. So awareness of self and environment. And talking about disorders of consciousness per se, with Stephen Norris, we propose actually some classification that is a good, kind of starting picture. Also showing you the potential differentiation between, or dissociation between arousal and awareness. So typically, arousal and awareness go together. So when you're conscious, hopefully you're still conscious and awake now, you're both highly awake and highly aware, but the deeper you go into sleep or generalize anesthesia or coma, your arousal decreases and the contents of consciousness as well. But there are some exceptions to it. REM sleep, for example, subjects are not arousable. Very difficult to arouse, but there is a lot of conscious experiences. And then finally, vegetative state is a state where patients can be awake with eyes open, but they show no signs of consciousness of self or environment. And vegetative state is not the only state where you can have that. You can also have this dissociation in some states like somnambulism or epileptic seizures. In contrast to vegetative state, minimally conscious state patients, they show some signs of consciousness, some purposeful behaviors, but are unable to communicate. And then finally, locked-in syndrome. These patients are completely conscious, but they are actually fully paralyzed, typically except for vertical eye movements. They are part of the differential diagnosis, but they are not, we don't consider them as a disorder of consciousness per se. But the diagnosis in these patients with disorders of consciousness is actually very tricky clinically, and if you use a clinical judgment rather than some tools like validated tools like the coma recovery scale, you can have up to 40% misdiagnosis in this patient population. And it remains a big also ethical problem to diagnose COVID consciousness in acute intensive care. And one relevance actually, one relevant point to make about this diagnosis of consciousness at the bedside, but also for neuromechanisms of consciousness, is that consciousness and responsiveness are not the same. And I'll present now some evidence showing this dissociation in a variety of conditions, but also in the brain mechanisms that support them. So basically, the neuroimaging approaches for consciousness at the very beginning when we started this, maybe about 25 years ago, were quite simple, and the basic idea was, for example, to compare wakefulness to sleep or wakefulness to anesthesia, kind of apple and oranges in a way, but states where you had actually signs of consciousness versus no signs of consciousness at all. And when you were doing this, there was a reliable finding that everybody could find, is that comparing wakefulness to sleep or wakefulness to anesthesia, you found the impairment of a widespread bilateral frontoparietal network, which is both in the lateral side and the midline. There was a widespread both posterior and anterior brain involvement to it. But again, as I said, what I said is our simple assumption was, I was also involved in the study, is that actually if you don't have any signs of consciousness, then it's most likely not there. But we actually know now that it's not necessarily the case. And one of the early lessons we learned with Adrian Owen and Stephen Norris when we designed this paradigm where we actually asked subjects, first healthy volunteers and patients, to imagine playing tennis in their head and actually look at the activation in specific areas. So imagine playing tennis activating the motor cortex, imagine moving around your home activating spatial areas. All the controls could do it, but to our surprise, actually, about 15 to 20% of patients in the vegetative state, no signs of consciousness at all at the bedside, were able to do this. And this has been now reproduced also with functional MRI paradigms by other teams or EEG, including a recent article by Jan Klassen et al. In New England Journal of Medicine, showing not only in the chronic but also in the acute ICU settings that about 15% of unresponsive patients show response to command using EEG. So you can actually see a very significant difference between periods where they ask, keep opening and closing your hand, like imagine doing it, versus not doing it. So this suggests that in quite a number of patients with severe brain damage leading to clinical unresponsiveness, you can find what is called now cognitive motor dissociation. So presence of covert consciousness despite no clinical responsiveness at all. Not only that, but you could still argue, well, this is still some kind of form of responsiveness by thought. All right, but take, for example, during sleep. During sleep, every night we go to sleep and we actually are completely unresponsive to environment. If you were asking me to imagine playing tennis when I'm sleeping, I would for sure not do it. But, actually, we did some recent experiments in the lab in Madison, Wisconsin with Giulio Tononi, and we saw that even during non-REM sleep, when you wake up subjects at night and you ask them if they were dreaming or not, you actually get dream reports 2/3 of the time. So during 2/3 of non-REM sleep, you have experiences. And a third of them is, oh, I was not there. I was not conscious. But then a third of them is, I was conscious and I can tell you of what. And a third of them is, I'm sure I was dreaming, but I don't remember. Nevertheless, even during non-REM sleep, and even during deep non-REM sleep, it's like half of the time, you can have covert awareness in the form of dreaming, which is kind of the most usual and pervasive dissociation between consciousness and responsiveness we can have. Consciousness is what disappears during dreamless sleep, but subjects awoken from sleep, non-REM sleep, report dreaming 2/3 of the time. Interestingly enough, during REM sleep, you can also have some periods where subjects are dreaming most of the time, but also some periods where they say, no, I was not there. Not only this is important, clinically and conceptually to show this dissociation, but it's also a very good opportunity for neuroscience to actually investigate differences in consciousness itself while equating responsiveness of behavior. So you have a pure conscious here where subjects are unresponsive anyway. So there's no confound of changing, like in wakefulness, I'm actually responsive, in sleep, I'm not. There is like within sleep, within the same state, you actually also with the same neuromodulation, So this is more looking at apples versus apples, but the main parameter that changes is consciousness itself, right? And so you actually have a very nice opportunity to look at what are the markers of covert awareness in unresponsive states, which is our clinical question of interest as well. And so when we did this recently with Francesca Siclari and Ben Bird and Lan Prosper Campos, what we found was that if you look at consciousness itself during sleep, the areas that make a difference, there is a very different answer that when you compare sleep to wakefulness. What you find is that the neural cortex of consciousness during sleep are actually mostly located in a posterior hot zone in the back of the brain, and not so much involvement of the frontal cortex. So there is more delta power during dreamless sleep than during periods of sleep with dreams in a posterior hot zone of like parietal, occipital, and temporal cortex in bilateral areas, medial and lateral. And this is, interestingly enough, like true both for non-REM sleep and REM sleep, which are very different states, very different neural modulation, very different physiology. But the same signature is there of that posterior hot zone, making a difference for consciousness itself, dissociated from confounds of responsiveness. And so to look at if that was really true, we kind of pushed it further and we tried to see if we could predict online with activity from a few electrodes here in the back of the brain, if subjects were dreaming or not during sleep. So we took actually the extremes of low and high delta power and low and high beta power, and predicted that if there's a lot of delta and not so much beta in the back of the brain, subjects will be unconscious. And the contrary, if there were really little delta, like local wake during sleep in the back, then you would actually be conscious. And just with these few electrodes in the back of the brain and these like simple measures, we actually could reach an accuracy predicting consciousness versus unconsciousness of 85% with a change value of 50. And if you look at the regions that were the most predictive, it's again in the back of the brain and not so much in the front. And so when dissociating consciousness from responsiveness during sleep, what I showed you here is that you find that the most predictive regions for experience to be there or not are located in the back of the brain. And actually, you can also use this approach in other conditions. For example, if you were taking patients in minimally conscious state versus vegetative state, they are very difficult to distinguish at the bedside, except that qualitatively, minimally conscious state patients show some positive signs of consciousness. So if you compare controls to vegetative state, basically we will find differences in the whole brain. But if you actually look more specifically for these, minimally conscious versus vegetative state within brain-matched patients for markers of consciousness, you'd actually find most differences being PET scan or functional MRI studies, or here a patient before versus after recovery from vegetative state. If you look within the same subject, within the same state, discarding like a lot of different compounds, then you will actually find that the most predictive areas are in the back of the brain. So this is kind of an exciting progress in the field of neuroscience, realizing better our methodological compounds and trying to really dissociate consciousness from its consequences, and looking also at subjective experience or comparing more within the same states. And what we find, like doing this kind of improvements in our methodologies, is that unlike previous approaches where we were comparing apples and oranges, like wakefulness versus sleep, if you're more specific, you find out that the more predictive areas for consciousness being present versus absent are mostly located in the back. And actually, interestingly enough, this fits quite well with some more remote and also recent evidence coming from lesion data from neurology. For example, in the 40s, you had several well-described cases from Penfield, Brickner, and others about resection of large prefrontal cortex areas, such as here in the patient described by Hebb and Penfield for epilepsy surgery, where despite this large prefrontal cortex resection, the patient was always conscious, and actually, if anything, his IQ improved. And then this very striking patient, Brickner, wrote a very long book about it, actually to make a point that no, there is an effect actually to frontal lobe resection, because Penfield was denying it. So Brickner described the frontal lobe syndrome in that book from this patient A, but actually if you look at it, what he describes is that patient A, after epilepsy surgery, which removed all these prefrontal cortex here, Brickner's study was removing the whole prefrontal cortex except for Broca area and area 6. This patient, despite that, never lost consciousness, and after extensive resection of bilateral frontal lobes, virtually all the prefrontal cortex, sparing only area 6 and Broca area, he was able to tour the Neurological Institute of New York in a party of 5, 2 of whom were distinguished neurologists, and none of them noticed anything unusual for more than an hour, suggesting you that you can actually have most of the prefrontal cortex removed and be clearly conscious. If anything, the patient was more emotional about the death of his friends. He was a bit aggressive, all that, but he was clearly conscious. And also, some studies in monkeys were done to confirm this, with more kind of clear-cut anatomical resections. And you had these two studies describing monkeys with full prefrontal cortex removed, and they were obviously there. This one became more aggressive, and then he was stealing some food from his colleague, so he had to be placed alone, but he was clearly there. These monkeys here from Jacobson, they were actually able to also do some complex tasks like remove problem solving of boxes to get some food or discrimination tasks. They were clearly conscious. So telling you both in humans and monkeys, you have some data showing that complete prefrontal or near complete prefrontal cortex resection doesn't affect consciousness, but there's some contrast with the back of the brain. If you actually look at studies from traumatic brain injury or anoxic brain injury, there seems to be more consequences when you actually lesion the back of the brain. This is a study from Campbell, actually looking at the predictors of outcome for traumatic brain injury and showing actually that if you lesion the posterior corpus callosum and surrounding white matter, then if you have a lesion there, you have 214 times chances to never recover from vegetative state, while actually the brainstem is only 7, and the prefrontal cortex was not predictive. And then also there are several case reports of patients with anoxic brain injury locating, like diffusion restriction located especially in the back of the brain. I had some cases as well that never recover. And more recently, also some more group studies for predictors of anoxic brain injury recovery and of different groups, showing that if you look at the different parts of the cortex separately, the most predictive areas will be parietal cortex, occipital cortex, precentral cortex, but not so much the front. And especially this study is interesting because they did a model trying to compare the whole full brain model versus only some parts of the brain. And they showed that actually if you take the whole brain together, including the frontal cortex, it's actually a less good model than only keeping occipital and parietal areas and a little bit of putamen. Again, suggesting that there is much more information about which areas will actually be able to, to support consciousness and can recover in the back versus the front of the brain. So lesion studies, like actually these neuroimaging studies I was talking about, dissociating consciousness versus responsiveness, show that these large prefrontal cortex lesions do not cause unconsciousness, while actually large posterior brain lesions predict permanent coma or vegetative state. Interestingly enough, it's not only in these global approaches in the level of consciousness that we are making this progress of better, dissociating consciousness from confounds or consequences, of behavioral responsiveness, for example, but also in the neural cortex of consciousness for the contents themselves in normal, awake brains. And there, the first studies we were doing, I did the same, were actually quite simple. We actually presented some threshold stimuli, target detection, you see them versus you don't see them. And when you actually do that, you can see that if you perceive a stimulus, if you detect the target, you'll have a massive, broad, widespread brain activation, including frontoparietal areas. But if you think about it, this is kind of a rough, kind of a gross contrast, because there's not only consciousness that differs, but also all the consequences of it in terms of working memory, preparation to responses, all these kind of consequences of it. And so now recently there has been some progress in the field where people try to be more refined and try to discard this confound better, for example, by trying to look at task irrelevant stimuli. And so that's an example, for example, where there's the picture and then something changes in the picture, sometimes you detect it or not. If it's task irrelevant, but if you're unaware, and then you have a little brain response, but not much. If it's task irrelevant, but you clearly saw it, you have mostly a posterior signature. And then when it becomes task irrelevant, it's basically activating the whole brain. Or here, another example, if you take a complex task, you have the whole brain recruited. But if you look at binocular rivalry with more simple stimuli, so the same picture, but then the image is changed, you will actually, your perception change for the same image. You would actually see that for simpler tasks, the neural cortex of consciousness are much more located in the back. If you use no report paradigms, using some proxies like optokinetic nystagmus for movements, that would be the same thing. If you actually don't ask to do a button press and an explicit report, you'll find the neural cortex of consciousness much more local. and especially much more posterior areas. Or like some other approaches, like trying to look at modulation by task relevance versus modulation of category specificity, so more what you experience. If you do that here with Rafi-Malak and intracranial recordings, you can find that task relevance is mostly related to activity in the front of the brain, and category specificity, which is relevant for consciousness, is much more in the back. Or some other approaches can be used, and the things we did, for example, is also looking at contents of consciousness during dreams. And dreams is also a very powerful approach because there is no task there. These are really spontaneous experiences where you can sometimes see a face or not, but there's within the same state, within dreaming, you look at what the different contents of consciousness can be. If you do that, you actually find some interesting results, even just with high-density EEG. So if subjects are dreaming of seeing a face versus not, you can see actually more activity in a region, more high-frequency power in REM sleep in a region close to FFA. If they are dreaming of spatial experiences, you'll find even just before the awakening is the strongest power in right parietal areas. If they are dreaming of moving, you find activation of an area close to MT. And if they dream of some speech, you can find some area close to Wernicke on the left side. And then also, if you ask them about if they have had spontaneous thoughts during sleep, or wakefulness, being non-REM sleep or REM sleep, you can actually find, just with these spontaneous experiences, which are actually no tasks, so relevant also for consciousness dissociated from consequences, you can actually find that you have that specific area in the mid-cingulate cortex that is common to the three states. And so all this to kind of review quick the evidence, but the big upshot of it is, there's an exciting progress made in consciousness science, and a little bit like a revolution also happening in the fact that, it seems to be that if you take better into account the confounds being, changes, neuromodulation between states, or consequences of consciousness such as behavior or task relevance, if you discard these better, you find that consciousness doesn't seem to really involve the whole brain, but is more evidence for a set of posterior brain areas that are both predictive for consciousness to be there or not, but also for different contents of consciousness to be there. And as I had said, for the global approach, consciousness versus there or not, this fits very well with what we know, for lesion data predicting unconsciousness. But also for contents of consciousness, actually, interestingly enough, this fits very well with what neurology tells us about content-specific changes. And the closest you can have for content-specific changes in consciousness, are actually the agnosias. And we know there's a series of different, agnosias you can have, which is kind of a piecewise loss of specific contents of consciousness or understanding, which is, it can go from cortical blindness or deafness to prosopagnosia, which is the inability to recognize faces, or achromatopsia for color, visual form agnosias. There can be loss of tactile percept, a lot of different ones. All these kind of different contents of consciousness, if you actually look at where agnosias, lesion lead to these kind of agnosias, you mostly find them in this kind of map of posterior horizon in the back of the brain. It's not that the prefrontal cortex lesions have no effect, but it's much more related to task settings, to task monitoring, behavior or emotion regulation, metacognition, which is more reflecting about consciousness or initiation of actions. But this is not the same. I had, for example, a patient I like to cite as an example. She came with acute unresponsiveness in the emergency department. People even thought it was a seizure. She had like a staring episode. But she was atypical in the presentation, and actually when I saw her with the acute presentation and how she was, I just pushed to have an MRI done, and we saw that actually what happened to her is that she had an acute, very kind of small, tiny stroke in the superior medial prefrontal cortex, and she had another one before, and she was actually in an acute kind of akinetic mutism. She recovered post-CPA, and I asked her, do you remember what happened to you? And she said, of course I remember everything. You know, I was at the church, and then actually the emergency department people came, and everybody was agitated, you know, around me. She could describe everything very well, but I didn't want to answer because I didn't know if my insurance would cover it. So she kind of made a story about it, you know, but she was clearly there, kind of showing you an acute case where responsiveness was absent, but consciousness is preserved. And this is kind of what, you know, what I was talking to you, the prefrontal cortex lesion can do that sometimes. So lesion evidence suggests that there's a lot of different agnosias or content-specific, you know, impairments of consciousness you can have in the back of the brain, and the front is more related to behavior. But actually, direct electrical stimulation is another type of clinical evidence going in the same direction. If you look at the, you know, big pictures in some reviews like Desmerger or Parvizi, you can actually see that if you stimulate the back of the cerebral cortex, you can actually elicit a lot of different percepts, being, you know, numbness or paresthesia or like some motor intention or some sounds. But actually the prefrontal cortex itself is experientially silent. You can elicit some movement or twitching, but actually not so much changes in how it feels like. And then there are some more examples like phosphenes for visual cortex, visual motion close to MT, out-of-body experience in the right parietal junction, or auditory hallucination for temporal cortex. So a lot of different percepts can actually be elicited by stimulation in the back of the brain. While actually the evidence for the front is more scarce, there is some good evidence that actually stimulation of the mid-cingulate cortex, which is close to the area we were finding for thoughts during dream, actually induces intrusive thoughts in 2 different studies. But for the rest, it's much less clear. There was one study from Blanke suggesting that 2 different regions of the prefrontal cortex could elicit hallucinations. And so they thought it might be involved in consciousness. But actually, if you look at this is something you could get from anywhere in the brain, more like a network effect. And if anything, it's more, if you look at Penfield, for example, results is more commonly found in the temporal lobe. So there's no strong evidence for frontal cortex there. So just to tell you that, interestingly enough, you know, the results from neuroimaging studies with this dissociation between consciousness and behavioral compounds are actually now more and more meeting the clinical evidence from neurology, suggesting that the back of the brain can actually be involved in specifying a lot of different contents, while the evidence for the front is much less clear. And this is kind of a picture of how we suggest it could work. There seems to be a posterior hot zone in the back of the brain, you know, involving parietal, occipital, temporal cortices, midline, and lateral. That seems to be both important for consciousness to be there or not, and also for specifying different contents of consciousness. So if you lesion this area, you have much, you know, more likelihood of staying in a permanent coma or vegetative state, but also you also have a lot of different contents that can actually be specified by, you know, temporal cortex. So it would be places or objects, some low-level features, touch, percepts, a lot of different contents that can be specified within the same area in the back of the brain. And there seems to be an overlap between the areas that are predictive for consciousness to be there or not, and then the areas that actually specify how it feels like. And this has to be really dissociated from consequences that seems to be specified by areas more in the front of the brain, being the motor report or verbal report. If I feel something, I'm able to tell you how it feels like, at least a part of it. And then some processing loops, you know, attention, working memory per se, that seem to be more slave systems for consciousness. And recent evidence actually suggests that for most of the behavior we have where we have to integrate different features together, consciousness seems to be necessary, while actually these kind of cognitive functions in a large part are consequences. So I wanted to briefly mention the potential relevance of what I just discussed for epilepsy. And one interesting parallel to draw is, you know, between epilepsy and sleep. So Hal Blumenfeld has done some beautiful work showing that in seizures with impaired responsiveness, complex partial seizures, you actually have a widespread involvement of, compared to baseline, you have a widespread involvement of a lot of different brain areas with some cortical slowing, sleep-like activity within most of the cortex, while only a part of the cortex is seizing. And actually looking at responsiveness per se, this is kind of what you find. Interestingly, you know, there's a lot of parallel to be drawn during sleep. In particular, what I was saying to you, that sleep-like activity is not per se a marker of unconsciousness. Like if you look at the whole brain itself, it has to be actually, you know, also be taken account that people can be unresponsive and have experiences. And if you look at the subjective reports of patients during focal seizures, you can actually find that in a lot of seizures where there is decreased responsiveness, like complex partial seizure, you can have preservation of at least some form of subjective experience, like in 35%. And also, if you take oral descriptions of focal seizures with recall, being auras or you know, the auras at the beginning of bigger seizures, in a lot of cases, well, experiences were there, but they were also abnormal. They were not connected to the environment, a bit dreamlike, but reflective consciousness was intact. However, attention was described as driven inwards. So this is very interesting and has actually really been studied in epilepsy, that this kind of dreamlike experiences, this kind of covert consciousness that can be there during seizures, and this dissociation between consciousness and responsiveness that could be there in terms of brain mechanisms. And that could really help us to understand really like what are the core mechanisms for loss of consciousness during seizures versus consequences on behavior. And both of them are important, but need to also be dissociated mechanistically if we want to intervene. And so patient subjective reports such as that covert experiences may be present in up to a third of focal seizures with impaired responsiveness. And there are also some content-specific impairment of consciousness, including attention being driven more inward, that may also be frequently present during focal aware seizures and may have behavioral consequences. And so one of the things we're trying to do now, and it's really just started, but we try to connect a lot of high-density EEG, you know, in patients with focal seizures, and looking at simple partial seizures and complex partial seizures, you know, and actually making a within-state contrast, looking at difference between these seizures with and without loss of consciousness. And what you see, if you actually compare seizures to baseline, you find widespread brain changes. As Hal said, there's sleep-like activity in the midline areas, especially here, and some seizure-like activity in temporal lobes. But if you compare within state, what actually is the most systematic difference, you find that the difference seems to be more in the back. Work in progress, but it's kind of going in that direction. We also look at, you know, really asking to patients, how did you feel during the seizure? Do you remember or not? Trying to find covert consciousness in some seizures and contrasting them with the ones with or without recall. And you can find in some first patients we did that, you know, comparing consciousness with, unresponsiveness with recall versus unresponsiveness without recall, you can find that if they actually were not conscious, there was more delta in the back of the brain as well. And also during post-ictal state, there's a lot more to do, also looking at within post-ictal state when patients recover consciousness versus before. So this is the kind of work we're doing now.
Do they do just free recall or recognition from a list?
So we do both. We do both behavior, where actually we ask them, you know, to recall, but also we ask them, so did you remember anything that was not related to the environment, so some feelings during the seizure, or what people did? So both the behavior and also what they felt like, you know, and both are very complementary. They can go together or separately. So this is kind of showing you, you know, within state paradigms during seizures are feasible, and I do think they are really promising to better understand what's going on in there, building on the work, you know, Hal did before on the sleep-like cortical activity and dream-like experiences, and we're actually doing that together with Hal, working on these. And then the last thing I wanted to mention, which is very complementary, is actually, you know, also that a way to really take into account these possible dissociation between consciousness and responsiveness, and like trying to take a general approach to consciousness itself, is also using some principles from theory, especially integrated information theory. Why do we need a theory? Well, I said to you, we're actually making progress, yeah? We're actually better now in how we're taking into account confounds, or we like design the new paradigms to try to better dissociate consciousness from consequences. That's good. But at the same time, there's still a lot of difficult cases, a lot of important things that remain unexplained. For example, there are some hard questions like, why is the cerebral cortex seems to be more involved and not the cerebellum, while the cerebellum has 4 times more neurons than the cortex? Why not afferent pathways? Why actually during seizures, and especially for us is very important, why is it that during generalized tonic-clonic seizures, when there's a lot of activity in the whole cortex, you lose consciousness? And what about these patients with brain islands, where only a part of the brain is actually seemed to be metabolically active, but the patient cannot say anything to us? It's very abnormal anatomy. What do we do there? On some other calls like ketamine anesthesia or sleepwalking, there are sometimes some strange behaviors, and you don't really know if there's anybody in there. To address, all these difficult cases, we argue that actually you need a general theory of consciousness that really can try to understand the mechanisms linking consciousness and brain activity in general terms. And for us, a principled systematic approach to a scientific explanation of consciousness should start by defining what consciousness is and the fundamental properties of consciousness, and then going from there to predict what kind of physical substrate could specify it. And in integrated information theory, we really look at consciousness and say, okay, what is always true of conscious experiences? And one thing we think is true is information. Every experience is specific. It's composed of a particular set of phenomenal distinctions bound together in various ways, which make it what it is and different from other experiences. There are differentiation in each experience is different. There's a lot of information in there. And also what we find is always true is consciousness is one. It's unitary. There's a lot of distinctions, a lot of components of your experience, but they're bound together in various ways. It's irreducible to independent subsets. And from these properties of information and integration, we actually go to try to find, from properties of experience, the properties of physical substrate that should specify it. And in particular, I talked about the fact that a theory predicts that to have high level of consciousness, to be highly conscious, you need a substrate, a brain that is both integrated and differentiated. So we actually tested this prediction over the last 10 years using a technique called TMS-EEG, where you basically do a magnetic stimulation and you look at how the brain resonates with EEG. And the prediction was that actually to be conscious, you need both integrated and integration and differentiation. And in unconscious states, you should find either no integration, so no connectivity, or no differentiation. And if you actually stimulate the brain with TMS, if you don't have integration, you'll have just a very local response. If you have no differentiation, you'll have a big response, but everybody's doing the same. Only if you have integration and differentiation should you find a complex response to TMS. And so TMS-EEG is the setup like this. We have a high-density EEG and we stimulate the brain. And it's a very powerful technique which has very high reproducibility. If you don't change any parameters, it's very, very similar even from one day to the next. But if you change anything, it's really sensitive to perturbation. So we actually did now apply this technique in about 100 subjects in a lot of different states. And the first study that was done with Marcello Massimini was actually during sleep. So if you stimulate versus wakefulness, and if you stimulate during wakefulness with TMS, what you can find is these are the tracing of a lot of different brain areas. The response is very complex and long-lasting, as predicted, And if you stimulate in non-REM sleep, it's either very local, or it can be big, but very simple, fitting with what I was saying to you, that consciousness seems to require both differentiation and integration to be there. During REM sleep, it's actually very different. Subjects are unresponsive, but are actually conscious, and what you find is there's a very complex response. In anesthesia, midazolam, propofol, xenon, 3 different agents you can find, and each time when subjects are unconscious, the response is very stereotypical. In ketamine, subjects were unresponsive, but conscious, and you could find a very complex response. So from these, even by just seeing the response, you can tell the difference between someone being conscious or not. But we wanted to kind of push this into a diagnostic index. And so what we did is we wanted a number, that can tell you if a patient is conscious or not. What we did is then try to summarize the response. Basically, in a binary matrix, you take the sources that are active versus not after statistical thresholding and time. And what you get is you have a 2D matrix of activation in response to TMS. And you can actually zip that and see how complex the response is. By just looking at differentiation over time of the significant sources. And what you actually find is that this index is actually capturing the properties that we want. That's what we call perturbational complexity index, or PCI. So if you have a very simple response, PCI is low. If you have a like local response, if you have a bigger response but it's stereotypical, PCI is also low. And it will only be high if you have differentiation and activation at the, differentiation and connectivity at the same time. And so basically, we applied this index, perturbational complexity index, in first a validation set where patients were able to report, so during transient states of unconsciousness like sleep and anesthesia of different kinds. And then we went to patients with disorders of consciousness where we don't know if they're there or not, and we actually looked at what we found there. And these are the results in the validation set. You can find here that if you draw a line, at PCI equal 0.31, you can actually have 100% accuracy and specificity to distinguish unconscious from conscious states, including patients with brain damage in the individual level, which I can tell you was never achieved in other methods I had tried. And what do you find in patients with disorders of consciousness? Well, if you apply TMS-EEG with this consciousness meter, PCI, in patients in minimally conscious state, you'll find that actually it detects consciousness with 95% sensitivity in these patients. And if you apply it in patients with vegetative state, what you find is actually you can have 3 different kinds of responses. Actually, some patients have no response at all. Wherever you stimulate in the brain, you'll find just a flat response to TMS. And TMS is a massive stimulation, but you find nothing there. And then in most patients, you actually can find a sleep-like response, like what you would have low complexity in propofol or anesthesia. But then in about 20% of patients, you find a very complex response, which, given our validation data set, suggests that there's most likely presence of covered consciousness there. And interestingly, this number, 19%, is very close to the number of patients that are detected when you use methods such as imagine playing tennis, as I was talking in the beginning. So both the active paradigms, the response to command through imaging, and this kind of theory-driven techniques actually point out to the fact that there seems to be about 15 to 20% of patients in the vegetative state that have, capacities for covered consciousness. So, but basically, that was kind of to show you in a nutshot that theory-driven approaches can also be very fruitful, from starting from consciousness itself and what should be very specific for consciousness. Dissociating from behavior, just really starting from properties of experience, you can derive some practical measures that you can actually use in some measurements that can then be applied to derive some information that can be very useful clinically for patients. And for example, you could say, well, if that's something we're testing now, but if you have no brain activity anywhere, without any sedation, anything, you try everywhere you can and you see no response to TMS at all, then it might be related to poor prognosis in these patients. While the ones that have sleep-like responses might be candidate for neuromodulation to try to wake them up and activate the cortex. And then in the patients that actually show some capacity for covered consciousness, you actually would like to really go to these patients and try to push to design some new brain-computer interfaces. And then finally, integrated information theory has also some explanatory powers. It can actually explain some known facts of consciousness in the brain, which gives this also some validity as an explanatory general framework. For example, the cerebellum, I was saying to you, has 4 times more neurons than the cortex. But if you look at the anatomy of it, it's very modular. And again, integrated information theory predicts that for consciousness to be there, you need both specialization and connectivity in the network to be there, as is actually supported by cerebral cortex. Same for basal ganglia loops. These are very kind of parallel systems that do not have the properties necessary to specify consciousness. And also relevant for seizures. For integrated information, it actually looks that balanced activity patterns should actually be necessary. We predict that actually you can have mostly silent brains and consciousness being still there, but if you have too much activity, like during epileptic seizures where the whole brain fires, we think there's a loss of information, there's a loss of complexity, and that should also be, leading to loss of consciousness. However, we never had the chance yet to apply some complexity measures to epileptic states, and that's something we really want to do in the future. Anyway, so to conclude, consciousness should be distinguished from responsiveness, and increasing evidence suggests it can be, and it's important both ethically for patients with brain damage, but also to really understand better what are the mechanisms, the neural substance of consciousness versus its consequences. I try to show you that lesion data from neurology within state and no report paradigms, for example during sleep, or also in conscious awake volunteers, provide evidence that many of the areas contributing to specific contents of consciousness are located in a posterior hot zone in the cerebral cortex, while the evidence for the front is still less clear. There's still a lot of work to do about this, especially task-related, conscious experiences. But overall, the evidence is much stronger for the back than for the front of the cerebral cortex for consciousness to be specified there. Interestingly enough, a lot of observational studies in epileptic seizures suggest the presence of also frequent dissociation between consciousness and responsiveness in epilepsy during focal seizures in particular. And their neural correlates are really still unknown, and I do think this is a really promising approach to try to better understand the mechanisms of loss of consciousness due to epilepsy. And within state paradigms, so looking at different types of seizures with and without responsiveness, with and without consciousness, and getting subjective reports, dissociating between awareness and responsiveness, as well as theory-driven measures of brain complexity, such as PCI or some variants of it, are promising approaches to better understand the mechanisms of seizure-induced loss of consciousness, and this is still work under progress, of course, but we really hope that this could really help design new preventative approaches to decrease morbidity and mortality due to impaired consciousness in patients with epilepsy. And so this is a huge team effort, the work I showed you, and I want to really thank Giulio Tononi, Chiara Cirelli, Marcello Massimini, Stephen Norris, and Hal Blumenfeld, for all their help and support over the years. And thank you for listening to me. And I have to show also 2 slides about CME and credits. But thank you. Thank you for listening.
For the TMS-EEG. For the excellent talk, first of all, and I learned a lot just in a matter of 1 hour. For the TMS-EEG, so what you look at is the pattern of response. Do you take in account the latencies, or because you have the high resolution, time resolution that there? Is the latency useful? And if when you have instead of a local response, you have a generalized response, the latency when that comes back to all over the brain, does it make sense? Or?
Yeah, I mean, both how long it lasts and also, I could show you this in there. Both how long it lasts and how differentiated it is will actually, matter for complexity. This is an overall, measure of complexity over the whole brain. We have some new measure now also called PCI, state-dependent, ST. Anyway, it's just published where you can also apply that in some parts of the brain only. But the latency and also how much it's spread and how differentiated the areas are all over contribute to complexity.
So these are data-driven. Obviously, there's a data-driven model that you're creating,
but at
the same time, you want to think you want to use that to go back and examine your hypothesis about consciousness role of different parts of the brain.
Yeah. So basically, it's theory-driven. We say we need from consciousness, you need integration and differentiation.
Okay.
So from there, we say, what is the best way to look at this? We say TMS is great. It's not sensory dependent. It's not depending on behavior. We look at the overall brain network, and we look at integration and differentiation together. Visually, you can see it. How to best quantify it? Then we find this trick of zipping, and then we found another one now, proxy that captured this. But this is fundamentally hypothesis-driven. Okay. Now showing you actually in the data that it seems that we capture the variability that is actually needed to differentiate consciousness and conscious states. But this is basically starting from consciousness and going to the brain then. Yeah.
Thank you.
Thank you for that interesting presentation.
Thank you.
I thought it was especially interesting to see you integrate so many tools to study this question, and I was wondering with the question of anterior versus posterior preservation of consciousness and brain injury, what do you think the role is of the thalamus, and what tools do you see as being most helpful in studying that?
So thalamus, if you look at the lesion evidence for vegetative state from the old days, thalamus and cortex both seem to matter. If you have broad lesions of the thalamus or broad lesion of the cerebral cortex, you can actually have vegetative state in both. I couldn't review everything here. I do think that the thalamus evidence is still, under progress to really dissociate different parts. We know that intralaminar nuclei, they project broadly to the whole brain. But from posterior versus anterior thalamus per se, I don't think there's very strong evidence saying that one is more important than the other ones. And if you look at, for example, evidence in coma patients or the clinical studies that are done in epilepsy, it seems that there could be some effect, kind of broad projection effect from both anterior and posterior part of the thalamus. We don't know yet. Yeah.
Thank you.
So this is actually part of already answered the question. So for the thalamus and also for the brainstem, like for example, reticular activating system.
Yeah.
So it's kind of more diffuse how you explain those,
Well, so basically, if we take this here, I have the brainstem here too.
Oh, yes.
We take this actually in what we call background condition or prerequisite. Mm-hmm. So you need basically, we think, an kind of awake cortex. Even during sleep, dreams would be related to local wake during sleep in the back of the brain, in most cases. Although one could argue that actually during non-REM sleep, the brainstem itself is actually very much down, and still you can have consciousness there. At the same time, if you have, preserved brainstem, you can also have a vegetative state.
Right.
So brainstem seems to be kind of necessary, also for breathing and blood flow, all that is necessary but not sufficient for it. And in these, it's like what we try to do also in animal studies is perturb, try to stimulate the brainstem or keep the brainstem constant activity constant and stimulate different parts of the brain, with optogenetics and try to wake up, parts of the cortex versus the brainstem and actually try to see what is making the most difference. Mm-hmm. And also what you can do is actually you look at the brainstem and you look at the cortex and you look if your effective consciousness can be best predicted by how the cortex changes. And what the brainstem does is actually just, kind of best explain that and how the consequences are on your physical substance, on your cortex itself. So it's more a matter of what is the main kind of variable versus things that influence it? Where's the core of the information I need to get to see if someone is conscious versus not, if that makes sense.
Yeah. Another thing I found it's particularly interesting, you mentioned about 15% or something like that kind of misdiagnosed that we think the patient is does not have any consciousness or anything, but they may have. And this kind of reminds me how do you feel this is you think about EEG reactivity? So we always know the EEG reactivity, yes or no, it's a, kind of overall it's good or bad. How you kind of feel
So there are ongoing studies actually trying to look at that, trying to compare these active and passive measures. Mm-hmm. But I don't think we have, typically it's if you have a normal PET scan, a normal MRI, an active EEG, sleep-wake cycle is more likely, but we don't understand very well yet, also for the TMS EEG. TMS EEG can show you some slow delta activity in the EEG and you still have a complex response versus not. So we actually need to better understand the links between the two, and that's also where, that kind of broad approach with the different techniques I showed also helps because then you can actually see what is the best predictor overall, but there's still more work to be done about this. Yeah.
Okay.
Any other questions? Thank you very much.
Thank you.